So let's talk about bulimia. What is it? Is it just eating a lot and throwing up, or are there other diagnostic criteria? And then is it more common than anorexia nervosa?
So bulimia nervosa is another eating disorder. It's actually more common than anorexia nervosa. It's probably at least twice as common, and has a similar kind of frequency of about 9 in 10 are female, similar demography. And it's an eating disorder that's associated with binge eating, that is the consumption of an excessive amount of food in a discrete period of time, and feeling out of control. So those are the two components of a binge. And one could even separate out subjective and objective binge eating, meaning that for some people, they may see eating 2 cookies as an excessive amount of food, and they may feel out of control. But in general, the studying of this disorder is about objective binge eating. So it's actually where we would all agree this is an excessive amount of food in a discrete period of time. And then compensating for that with behaviors such as self-induced vomiting, laxative use, diuretic use, excessive exercise. So somebody might go on a binge and then go into extreme exercise to compensate. So again, with a preoccupation with body shape and weight, another key part of it, and also a considerable distress about one's body image.
What are some of the triggers for the development of bulimia nervosa, and how early in life does it tend to, or can it begin?
Well, bulimia nervosa generally occurs or has an onset a little later than that puberty, generally in the mid-adolescent period, but the precipitants or the predisposing factors actually may be being overweight or being perceived as being overweight. And again, dieting is a key predisposing factor here for this. If there was a way that we could address both body image discomfort and dieting in young people, and the issue is for us is that is becoming more a concern younger and younger in life. So when I started the eating disorders program at Mass General in 1980 and 81, this was largely a teenage phenomenon, and now we see kids as young as 7 and 8 already quite concerned about their body shape and weight. And sometimes parents quite concerned about their infants' weight even at a younger age, at 2 and 3. So that they're at 50th percentile when they would like them at the 25th percentile. So the concern about body shape and weight is become a major part of our culture.
Can you talk about mortality rates among people who have this?
Well, with bulimia nervosa, this is where there's an interesting area here, where there are a number of people who have anorexia nervosa who then go on to develop bulimia nervosa. Or anorexia nervosa, there are 2 types of subtypes of anorexia nervosa. A restricting subtype where you limit the consumption of your intake, and then there's a binging purging type of anorexia nervosa where you actually binge and purge and lose this weight. But bulimia nervosa is a disorder where one is thought to be of normal weight, maybe overweight, but is not underweight. And generally, if they're underweight, they would be more in this area of anorexia nervosa binge purge subtype. So in our studies, we find that the individuals who only have bulimia nervosa, meaning that they may have depression or may have substance use problems or whatnot, but they never had a history of anorexia nervosa, their mortality rate is not as great. But those with the history of anorexia nervosa, the mortality rate is significantly increased and of great concern. Now, in bulimia nervosa, there are health conditions. First of all, it's not uncommonly associated with substance use disorder. There can be a history of trauma, and so there may be a dissociative disorder associated with it. There may be a history of sexual abuse. The kleptomania is another comorbid condition, and as I was talking to the residents yesterday, and I asked them if they ever asked any patient about, kleptomania. None of the 30 raised their hand. It's actually some of these individuals will steal food, will steal money to buy food, will steal clothes. They're involved in a series of impulsive behaviors. And that may be one behavior, substance use may be another. And it's important to be able to ask about these things, not in a critical way or judgmental way, but as an understanding, because if we cannot be empathic with these individuals in trying to understand them, who's going to be? So I think it's a key area of inquiry. And there can be other drugs that may be used here, so that and I think that's apart from alcohol to help manage weight and whatnot, and whether that's the use of Adderall or some of the stimulants have become used to manage or help in weight control. So those also need to be thought about and inquired about.
And what are some of the medical conditions that might develop as a result of?
So in bulimia,
medical or psychological conditions.
The medical conditions. One of the more serious is hypokalemia, the loss of potassium, and that's important because that hypokalemia or loss of low potassium can be associated with arrhythmias and can lead to sudden death. So that needs to be addressed seriously. They can have enlarged parotid glands, and many may not know what a parotid gland is, but it's in the jaw, and those who've known people with mumps might know what that might look like. And the individuals may wear their hair in a way so that it's not well noticed. But it's important to know that those enlarged parotid glands will normalize when these behaviors normalize. Destruction of dental enamel, perimolalysis, a big problem, and the dentists sometimes make these referrals. And the correction of that destruction of dental enamel can be pretty expensive. So but it's important to know that that's clearly a complication of this. And then there are bowel problems that can be associated with this laxative or chronic laxative use that can lead to some very serious complications.
And are there other results from your NIH study that you haven't touched on yet that you want to highlight?
So we did find a high, an elevated frequency of alcohol use and drug use in this population. So one really does need to inquire about that. We also were able to follow the people over time and actually look at pregnancy, and because that's always, first of all, there's the question: can people become pregnant? And then what would be the impact on the pregnancy or the fetus? Obviously, a great concern to all of us. as you might expect, there are better outcomes if the eating disorder is under control at the time one becomes pregnant. First of all, with the newer technologies, even the women who were underweight can become, or often can become pregnant. But but then the challenges begin to occur as their body changes, and you know, we've had people who had to be fed by nasogastric tube for the last 3 months of their pregnancies because they just weren't taking in enough. We had one woman who, you know, was in her 7th month of pregnancy before she acknowledged to anyone that she was possibly pregnant, and so it's a concern, but in general, okay, I just want to say, with the proper supervision and so forth, there were some smaller babies, but no major problems, but there was some risk, increased risk for postpartum depression, and that's an area that we need to look carefully at, because there's the attention during the pregnancy, and then following the pregnancy, what happens to one's body, and how one comes to grips with that, or and values or devalues oneself accordingly, and the supports around them. So that needs to be much more carefully monitored.
And so this discussion around pregnancy, this would apply to both anorexia nervosa and bulimia, or?
It applies to both anorexia and bulimia. Now, obviously, I mean, if you're severely underweight, I mean, if you're 65 pounds, or I don't know, whatever, you know, your BMI is 10, you're not going to become pregnant. But I'm talking about those who get to a place where that can be possible. So, but the point being that these individuals are going to have to be very carefully monitored during the course of pregnancy. And then there's the next question as to what happens to the next generation here, both in terms of the genetics, but also in terms of how weight is managed, and the dynamics between mom and daughter, or mom and son. Is
there any indication that there are genetic factors, that there's some genetic predisposition to?
Well, there are. Let me just say, eating disorders are brain disorders, so that there's clear neurobiology of these disorders. There are neuropsychological dysfunction. There are changes in the brain scans. There are changes in neurotransmitters. So we know that it's a brain disorder, and there are genetic disorders, so that there is an increased frequency in families. So if you have a family member with this disorder, your risk is substantially increased. The identical twins are much more likely to be concordant for this disorder. One of the first patients I ever saw in my training in child psychiatry was an identical twin, both of whom had anorexia nervosa and were both in the hospital at the time. But so that they are genetic disorders. Now the question is there a gene for an eating disorder, or is there a gene for a potential predisposing factor to the eating disorder? In other words, is there a gene for perfectionism, or a gene for compulsivity? So that's what essentially needs to be determined, is under study.
Excellent. Let's see, what are some treatment approaches that have proven effective for bulimia?
So for bulimia, I think people are pretty, I think it's pretty strong data that cognitive behavioral therapy is a useful intervention. And those are therapies focused on altering these thoughts and behaviors. It's manual based, so you can structure it. It's relatively short term, and it's useful for a certain percentage of people with bulimia, whether it's 50% or not, but somewhere in there. But then there's a group that needs something else, and there are other kinds of treatments, and generally individuals are on some form of, or in psychotherapy, and also on receiving some medication. So the SSRIs, the selective serotonin reuptake inhibitors, such as fluoxetine and sertraline, they've been studied and have found to be useful in bulimia, but they're not a magic bullet. They can be helpful, and so they're often used in combination with with psychotherapy. Then there are other forms of psychotherapy other than CBT that are used, like DBT, dialectical behavior therapy, and and I think there are newer treatments being used. And then there's family-based therapy for the younger patient, because it's hard to treat this condition in a teenager without including the family. So there are family therapy approaches as well. And I think the outlook in bulimia is more promising than in anorexia nervosa, but again, we need to develop better treatments. And then there are individuals who have other some of these other conditions that need to be addressed as well, like the depression, anxiety, and this self-injurious behaviors. This cutting wasn't as much a problem 25 years ago or 30 years ago, at least amongst the clinicians I speak with, but have now become much more present as a way of managing anxiety and need to be addressed as well.